Good morning, everyone, and welcome to Cardiac Sciences Grand Rounds for the 3rd of June, 2025. This morning we have a special guest visiting us from the north, which is very unusual for Calgary, actually. Dr. Gurmeet Singh is from Edmonton. He is the Zone Director of Cardiovascular Intensive Care in Edmonton and a member of the Departments of Surgery and Intensive Care up there. He comes down today as the annual invitee for our cardiology fellows, which is a great honor for you, Dr. Singh. Congratulations for that. Today he is going to talk about rescue with mechanical circulatory support. Welcome, Dr. Singh, to Calgary.
Thank you very much. Appreciate the nice introduction. And can everybody hear me okay online? Okay, I got a thumbs up. Usually I'm a mumbler and nobody can hear me, but I think it's most of the time people are trying to ignore me, which makes the invitation from the trainee side particularly special because usually they also try to ignore me. And well, with good reason. They probably know a lot more than I ever did and are a lot more engaged. And so it is a particular honor to have that hoisted upon me. I will say this, Calgary is very special to me. It's special because it was sort of the finishing school for my professional training. I did my critical care training here. So it's the fault of some of the people in this room as to what I've become or how I do it. But even more importantly, you build these personal, professional, and interprofessional bonds that carry you through a lifetime. So there's a handful of people in this room who mean a great deal to me, and some people who I've known for decades now, and it's really special. So thank you for that. I'm going to talk about, just make sure this is clicked over here. Yeah. I'm going to be talking about rescue temporary mechanical circulatory support for cardiogenic shock. And it's a very, very popular topic these days, cardiogenic shock and device A versus device B, but I want to provide this in the framework of some pragmatism and how do we actually practice real world. By way of disclosures, in the remote past, I've had honorarium and travel support from Medtronic and Abbott. My partner works for Abbott, but we completely recuse ourselves from anything that has anything to do with each other. And I'm not talking about any specific devices today, only principles, so there should be no conflicts. I started in the mechanical circulatory support arena as an interest as a trainee in the late 1990s. Just mumble that. And so I implanted my very first HeartMate XVE in 2000. And here we are a handful of years later, and the technology has advanced tremendously. And we're sort of making increasing gains to the point now where, from the Momentum trial, the midterm durability of a durable LVAD, if you're having a good run, is threatening to approach that of transplantation. We're not there yet, but this is where the technology is evolved and is rapidly evolving. My further disclosures, I'm like the Ted Lasso of cardiovascular sciences. I'm like, I believe, right? I don't want to say that I'm evangelical, but you have to have a certain belief in an area when there's evidence that still needs to be accumulated. I work in Edmonton, as you know. Please don't hold it too much against me. As I said, I do have a great fondness for Calgary. So what I'm presenting to you is not just my way of doing things, but it's the Maz way, right? This is an approach that we've all sort of bought into. So what does this very highly rated hockey player have in common with this golfer, have in common with this scuba diver? Any guesses? They all presented in decompensated cardiogenic shock and eventually went on to be rescued with our bridge-to-bridge strategies to have durable LVADs implanted. The mortality for cardiogenic shock, depending what you read, is 30 to 60%. So we're still having half of these patients who present acutely decompensate. And so for the purposes of what we're discussing here, we're talking about what people refer to now as Sky E and Sky D. I tend not to use the Sky classification when I look at a patient because I'm looking at that patient with a different lens, and that lens is how am I going to rescue you? Not whether you have shock or not, but how do you need to be rescued? And we'll talk a little bit about it. And you have to make these decisions rapidly and in a very timely fashion. Otherwise, mortality is sure to follow, right? And we've all seen this. I particularly remember a case of a young person at the Grey Nuns Hospital in his 30s. You get a call, and 20 minutes later, he's dead before we could even mobilize a team to go cannulate to rescue him. The evidence in this area is either single center or largely retrospective and observational, okay? But there is reduced mortality for cardiogenic shock if we initiate MCS early. As I was fond of being told as a trainee, the Lazarus procedure doesn't work. You may think you're training in cardiac surgery, but you cannot raise the dead. So, what are our goals for these patients? Well, we want to prevent further decompensation. So you want to prevent a rising LVEDP. You want to reduce the risk of developing pulmonary edema and thereby hypoxemia. And pulmonary edema and hypoxemia are one thing, but that can further degenerate with capillary injury to full-blown ARDS of a different etiology. You want to prevent ongoing left ventricular ischemia, and you certainly want to prevent worsening cardiac dysfunction once you get into that spiral. You want to be able to assess somebody's neurologic status and end organ function after you've tried to rescue them. And that's why we are big proponents of the bridge-to-bridge strategy. There's not just one device that suits every patient, okay? Today I'm going to focus on a couple of cases to illustrate how we think about these complex situations. I'm going to talk about peripheral VA ECMO, central strategies, be they VA ECMO or BIVAD central cannulations with paracorporeal pumps. And I will talk briefly, very briefly, about the paracorporeal the percutaneous microaxial pump that everybody is so excited about these days. So the question is always, so you have this array of choices available to you, which device do we use, and how do we make those decisions, right? The problem is there are actually no really good clear-cut guidelines. There's no really definitive guidance on how you should decide to rescue somebody or which device you should deploy. This is a 38-year-old male who presented to hospital in Red Deer, feeling just unwell, low energy, fatigued, peripheral edema. ECG's done, and it's AFib in the 160s. So what's the first thing that's done? Try to slow him down. So he gets some IV metoprolol. And this is followed by complete cardiovascular collapse. He's hypotensive, he's gray. Now he started on pressors, now he's hypoxemic, now he's being intubated. And a TEE is done. His LVEF is less than 10%. He's got biventricular failure. And shock team call is originated from Red Deer to us. Okay, so now just a quick poll of everybody here. Hands up if you would put this man on peripheral VA ECMO. A resounding 1, 2, 3 people, okay. Anybody for central VA ECMO or paracorporeal central BIVAD type situation? Anybody? Nobody? Okay. And would anybody use the I word, the Impella, for this patient? No, nobody. Nobody's interested in the Impella. Okay, don't tell Johnson & Johnson. We did something different, and our manuscript for this strategy is now in review for the last several months, which I hope is a good sign. We decided to cannulate this guy centrally, and I'll explain to you why. So we opened his sternum and put him on central VA ECMO, but we put a 30-32 French cannula in the apex of the left ventricle, right, to really decompress his left heart. And so we drain from the right, and the cannula goes up from the right femoral vein up into the right atrium to the SVC, and we get excellent drainage. And then when we decide that we're ready to transition him over, we just cut, clamp, and pull the venous line at the bedside, and all of a sudden we have an LVAD. A temporary LVAD, but an LVAD nonetheless, without having to go back to the operating room. And we still can mobilize them and so on and so forth. So we do CV-ICU bedside conversion from ECMO, central ECMO, to an oxy LVAD, and then we can convert them just by cutting out the oxygenator at the bedside to a pure LVAD. One trip to the OR, that's it. Most importantly, however, is the physiology that is behind this, the rationale. And I'm a big believer in pressure volume loops, so you'll see a couple here. But you can see that the load-independent contractility, right, when you develop cardiogenic shock, is completely depressed, right? And the stroke volume is reduced, the LV-EDP is higher, the LV and diastolic volume is higher. So we put people on ECMO to rescue them, and what do? You actually make those things worse. If you look at this curves and look at the flow, as if you get up to high flow from a blue, which is your cardiogenic shock curve, up to the red, which is your high flow curve, you're actually increasing the LV-EDP, you're increasing the afterload. This is illustrated a little bit better here as well. You can see that the red represents the ECMO curve, and the arterial elastance is higher, so you've raised your afterload in the context of a reduced stroke work and reduced stroke volume and higher systolic and diastolic pressures. So when we cannulate somebody, we put that big cannula in the apex. You can even do that apical cannulation if you wanted with a mini thoracotomy, and we have done that for peripheral VA ECMOs when we want to vent that heart or unload it properly. And so then we get antegrade flow, we get superior flows, we get full biventricular support, really, right? And you get cerebral and coronary oxygenation is guaranteed, as opposed to some of the complexities with retrograde flow with peripheral VA ECMO. As I said, you can do it with a mini thoracotomy and a mini sternotomy if you want, but biventricular unloading is possible. I mean, they say that there's bleeding and tamponade that can occur as a result of this. I've never seen that at our center, never seen any bleeding complications. Infection, thrombosis, but the biggest concern, right, is you're going to develop adhesions. And we're not putting these people on typically for an hour or two. It's a prolonged period of time sometimes. And so going back in to put in their durable LVAD can be dicey indeed. So for that first patient, you know, he had a rate tachyarrhythmia-mediated cardiomyopathy. And we cannulated him as I described. And a couple of weeks later, he seemed to be recovering. So we didn't have to put a durable LVAD in him after all. And we just decannulated and patched the apex. Goes home, good as new, sort of. So when we use these central BIVAD type strategies, you can actually still mobilize your patients. Okay, this is Marty. Marty is a big hockey fan, as you can see, and he had congenital aortic stenosis. He had his fourth sternotomy done for complex aortic and mitral valve disease in the context of severe pulmonary hypertension and RV dysfunction. A lot of problems perioperatively, post-cardiotomy shock, unable to separate. And so the decision was made to put Marty on a BIVAD, and because he had a mechanical aortic valve, the aorta was patched with bovine pericardium to basically exclude it, so that would not create a problem for flow moving forward. Marty had a very difficult course, initially woke up paraplegic, which actually subsequently resolved and improved. He developed HIT. So we had to wait 3 months for the antibodies to go away before we could contemplate next surgical strategies. He developed multi-drug resistant Pseudomonas infections recurrently, VAP, HAPS, and just really problematic. And then he got to a point where things seemed to be improving, and he was not a transplant candidate because of the RV failure and the pulmonary hypertension primarily, right? So the theory was that, well, we need to get the RVAD explanted and see if we can transition his temporary LVAD to a durable LVAD. And if he can, then we can send him home like the other 105 patients we have out in the community and let him wait for a transplant as his PA pressures come down over the next few years. Unfortunately, he started to develop recurrent RV failure. He basically failed a few weeks after the RVAD was explanted. And it looked like when we did further caths and imaging that that patch had dehisced and his mechanical valve was partially thrombosed open, and he had significant AI and was going into worse right ventricular failure and congestive hepatopathy. And we met as teams and we said, okay, well, how are we going to rescue Marty out of this? And there was no good options. There was like, we think that that patch probably was infected with Pseudomonas, and in the first place, it was a very calcified aorta, and there's no way we're going to be able to sew it up again. There's no good percutaneous option, we were told, and we were not going to go backwards and put an RVAD into it. So it was a very difficult conversation with Marty that this is now going to be the end of your life. Marty said to me, you know, the one thing he wished he could have done is gone to another hockey game with his brother, Bart. So we arranged it. Here's Marty with his Centromag LVAD being loaded up into the ambulance, and that big smile of his, which was so infectious. There we are at Rogers Place. We had an incredible amount of support from the organization, not paid for the tickets ourselves, but not that kind of support, but just in terms of security and things like that. Like, you know, it was actually pretty interesting because all this stuff, although, you know, OEG, or Oilers Entertainment Group, was really willing to be very proactive and help us with this, they, you know, you had to go through NHL security because we had to bring the ambulance into the back of the arena where the players come in from. It was a big deal. But there were no hitches. Like, the organization was so helpful with respect to logistics. And we had EMTs volunteer on their off time to come and do the transport and wait with us. And they got to, you know, sit up there and watch a game. So it was a wonderful experience. And then a few days after that, Marty decompensated a little bit further and then ultimately succumbed to his critical illness, so he's no longer with us. So the strategy is a great physiologic strategy, but you also have to know when you have to exit, and it becomes difficult if you get on that bridge to nowhere. That was a very difficult case with Marty. Every program that does rescue for any kind of critical illness, we all face these problems. Whether it's, are you going to dialyze an elderly patient, or how far down the mechanical support rein are you going to go, and now your patient is lucid, and you have to try to engage with them. So it's difficult. But you have to have that established in your mind, I think, ahead of time. This gentleman, in his early 60s, was not doing very well at home, just kind of gray, sweaty, clammy, having on and off, stuttering, chest pain. Wife kept prompting him, go to the hospital, go to the hospital, go to the hospital. Surprisingly, he never went to the hospital. Stop me if you've heard this before, right? So he eventually does present to hospital, and his ECG, he's got Q waves, but he's got persistent ST segment elevation. He's cathed. There's an LAD lesion there, and they do an LV gram. They're like, uh-oh. Do some further imaging, and he's got a ventricular septal rupture. So now he's developing decompensation in the cath lab. He's hypotensive, short of breath. He's going to pulmonary edema. What should we do? Would anybody in this room offer this guy rescue? Always the surgeons. I love it. Okay. And if so, which device? Would you put him on peripheral? Would you put him on central? Or would you put him on an Impella? Hands up for peripheral VA ECMO. Hands up for central. And any votes for Impella? Now, as I'm asking and soliciting your opinions, I just want to emphasize, I don't think there's a right or a wrong answer to these cases. We're just trying to establish a way of thinking about these cases and coming to a consensus. The decision was made to put him on peripheral VA ECMO. He was about a week out, and we thought, well, he just needs a week. Keep that sternum fresh if you can, and just he's ejecting nicely enough. He's probably not going to need an additional venting, but keeping him ejecting was a little bit challenging. This is the way we do our peripheral ECMO. We typically use a 25 Biomedicus multi-port cannula. On the arterial side, we do not directly cannulate the vessel. We always use a side graft, different than what's illustrated here in terms of size. But when you are finished with your ECMO run, you can simply amputate that graft and you don't need to do a formal arterioplasty. Our infusion, so we use an 8mm gel weave for that infusion limb, and we use either a 1/4 3/8 connector right into that side graft or often just a 22 AOPA inside the graft. So when you're making these decisions, whether you do it peripheral, you said, okay, you know what, we'll just put you on central, we'll wait a week and take you back and do the formal repair. There's no right or wrong answer, I don't think, but I think you need to consider the patient. You need to consider what's going on with end organ function. What is available to you at your center? Where can you support the patient easiest? How can the patient be supported? What is the plan for the next steps? And ultimately, what's the team's comfort? What's the surgeon's comfort with these things, right? Things that we might do at our center when we get called from Saskatoon, maybe they're less comfortable doing those things, and we have to have conversations with our colleagues as to see what the best solutions are. Now, of course, it's rapid when you do peripheral VA ECMO. Everyone says that until you have to do it. It can be done at the bedside. You don't require their sternotomy. And then it's an interesting phenomena if you look at registry data that post-cardiotomy shock has lower mortality with peripheral VA ECMO. I've never seen a patient who didn't come off pump, who didn't really need to be on pump still, which means putting them on a partial bypass with higher LV afterload. How's that going to help that LV recover? So I've never understood that registry data. So that to me means people are using, in those contexts, the VA ECMO more as a, I don't want to use higher dose inotropes, but because I think the heart is going to recover, as to the traditional way that I think of post-cardiotomy shock. But you are limited in how much flow, you're limited in how good your drainage can be. You don't get you don't get any LV unloading, you get some circulatory support. And you're at risk for differential hypoxemia, limb ischemia. And this is the important stuff. Remember those pressure volume curves I showed? Increased afterload, which is going to result in LV distension. And of course, you can't mobilize your patients. It's very challenging in very obese patients, or if you have severe peripheral vascular disease. We do run into this frequently. Because of the partial biventricular support, you don't get complete hemodynamic support. And you have to maintain LV ejection to try to limit the LV distension. So not only LV distension, but you then get LV ischemia, you get worsening mitral regurgitation, and then pulmonary edema. All of these things impair LV recovery, which is what the aim of mechanical support should be. So if you have to unload these left ventricles and you want to do it in a mechanical way, because you've got this higher afterload that we talked about, lower stroke work, higher end diastolic volumes and pressures, You can do this mechanically multiple ways. You can do create a PFO. There's multiple strategies on how you vent. I've always been frustrated whenever we've tried to take a cannula and cross the septum and try to drain from the LA to add it into the ECMO circuit. It just, either gets displaced or we don't get good flow. We don't have the right cannulas. We don't really decompress the left heart. I mentioned earlier differential hypoxemia, also called the Harlequin syndrome, right? So this is interesting, right? Harlequin now means various colors, variegated, and we think of that character in the pantomime. But originally, Harlequin in Middle Dutch comes from Elekin, which refers to hell and a demon, and the Old French of éloquent, same idea, hell and a demon. And yeah, managing differential hypoxemia can be hellish because you have a left ventricle that's ejecting relatively deoxygenated blood, forcing itself against retrograde flow of hyperoxygenated blood from your ECMO circuit. This creates a mixing cloud that is going to move variously depending on the LV contractility and how much ECMO flow you do. Well, if you think you want to just overcome the mixing cloud by increasing your LV flow, or your ECMO flow, you can certainly do that, but you're going to do that at the price of increasing LV afterload, right? And so it becomes a decision about what is the more critical problem here. Is it their hypoxemia and pulmonary edema and ARDS, or is it the LV function? If you can get away with partial cardiac support, we've used VAV ECMO to get oxygenated blood to the brain and the coronaries, but you lose circulatory flow with that because some of your blood is being diverted into the venous circuit to provide that oxygenated blood to the brain and the coronaries. When it comes to limb ischemia, people talk about putting distal perfusion catheters in, and it's very variable as to who you talk to, whether you should do it right away or whether it should be done PRN. And there's a lot of debate about that in the literature. Looks something like that. But often, even with perfusion limbs, the limb winds up looking like this. And ischemic limbs do correlate with mortality, right, and poor outcomes. Again, this is why we use the strategy of the side graft. It's more time consuming to implant initially, but the benefits are there. A little word about the microaxial percutaneous LVAD, the Impella. The Impella has been around for a long time. I don't know if people are always aware of this. This is a technology that has been being refined for the last couple of decades, trying to find the optimal usage and indication. And I'm not sure we're quite there yet, to be quite honest. I first became aware of the Impella in 2000. It's been around for more than 25 years. This study was what prompted so much excitement in our communities about putting microaxial flow pumps in infarct-related cardiogenic shock. Just thinking about it, when you look at the study, you give somebody a 2.5, 3 liters of flow. You're never really getting 3.5 liters. Let's say you do. You give them 3.5 liters of flow. Is that enough to reverse cardiogenic shock in a person who's like 80, 90 kilos? So as you can see here, the mortality for the standard of care group was almost 60%, so very high mortality, right, in this cardiogenic shock population. And the Impella, still 46% mortality, so an improvement, right? People are excited about this, justifiably so. But here's how you have to look at the study a little bit more carefully. Like, over 40% of those patients wound up on renal replacement therapy in the Impella group. They weren't just straightforward cases. They were really sick, probably because they were flowing so high on the Impella to try to reverse the shock that you're creating hemolysis, right? So not enough flow for that pump. Even more interesting is, despite flowing super high, almost 16% of the Impella group had escalation to other forms of mechanical circulatory support compared to 21% from the standard of care. So that's really quite telling. And it's an expensive pump, right? What is it, $60,000 Canadian for a 5.5 now? So we have to think about, is that the best deployment of this pump? I think there are other places that we can consider it, right? Now, people talk about ECPella fully unloading like the left ventricle while you're on ECMO, which is exactly what I've been, espousing. Well, I can do that with a few $100s with that 32 French cannula in the apex. Yeah, it's a pain in the butt, and yeah, you have to open somebody's chest and so forth. But there may be cases in which that is a useful strategy. So you crash somebody onto peripheral ECMO, right? Like somebody who's got ischemic VSD. And now there's some case studies, Cleveland Clinic showing, with complications of myocardial infarction, they've had better results using percutaneous devices. Now, reverse their end organ failure or make sure they're neurologically okay, put a 5.5 in, and then decannulate them, move them around, and then take them to the OR. All of which adds to the expense and the strategizing around how it best to deploy a novel technology. We're still trying to figure it out. Okay, question for the audience. What intervention improved out-of-hospital cardiac survival by 53%? This is the old guess what I'm thinking question that you get at rounds, right? So what intervention improved out-of-hospital cardiac arrest survival by 53%? Think about that. American Heart Association, Heart and Stroke Foundation of Canada, all part of the ILCOR councils. And their recommendations for ECPR, weak recommendations with very low certainty of evidence, okay? Very low certainty of evidence. And it may be considered in selected cases where you fail conventional CPR. The AHA, insufficient evidence for routine deployment, can consider it, in select cases. This is the famous photo of the Vancouver physician who arrested while exercising and went into the emergency department, had ECPR performed, came out right as rain, right? Was cannulated very, very rapidly. Right place, right time, right system. In 2010, you might have seen this photo in the news, the Paris Marathon a 45-year-old at the 25-kilometer mark drops. VF arrest, CPR started, on-scene ECMO cannulation within 45 minutes. Decannulated 10 days later, severe neurologic injury. So, I'm just going to walk you through this. I apologize for the confusing slide. This is actually in the original form. It has builds, so it's a little bit easier to follow, but in order to not screw up all my formatting, I'm just presenting this as a PDF. So this is, I find, very useful, right? Like I dug this up years ago, but the French have been doing out-of-hospital cardiac arrest, ECPR, for years. They've got a lot of good experience and I think some good lessons. And so they have some national guidelines for ECPR. So 3 categories: possible indications, uncertainty, and where it's absolutely not indicated. So uncertainty, you have refractory cardiac arrest. Okay, is it a drug intoxication? Is it hypothermia? That's a possible consideration. Do they have signs of life during CPR? Consideration. The other thing that's not on here that I find very useful is if they even have any temporary ROSC. If they've any intermittent temporary ROSC, then yeah, that's another, in my mind, positive prognostic feature. On the other hand, if they've got severe comorbidities, or it's an unwitnessed arrest for 0 to 5 minutes, so that's that no flow time, not an indication. So if it's unwitnessed arrest, don't even bother. On the other hand, if it's less than that, and the low flow time where you started CPR is less than 100 minutes, and your end tidal is over 10, then you can consider it. And also, I think that's not on this slide, but there's a lot of good data from the early 2000s showing a lactate of approximately 12 as being a sort of a helpful cutoff, right? Rhythm is really important, I think, for optimizing success. We can do these things to anybody, but if you want to do it to people where we are going to be successful, you have to be strategic. And VTVF is the place where the money is. So I've always kind of found that to be quite helpful. So when I ask you what intervention improved out-of-hospital cardiac survival by 53%, you're probably thinking ECPR. Nope. This was published in Circulation about 10 years ago. Between 2002 and 2011, the out-of-hospital cardiac arrest survival in Canada improved by 53%. And how did we do that? Improving that chain of response, bystander CPR, better transport systems, training people with defibrillators, and so on and so forth. So you can use technology and leverage technology, but you need to be aware of the limitations downstream and upstream of deploying such technologies, and you need to put the technology in a position to actually succeed. 37-year-old Gravida 1, Para 1, admitted to hospital, tertiary care hospital across the river in Edmonton. She's admitted with preeclampsia. Eventually she gives birth, cardiovascular collapse secondary to an amniotic fluid embolism, CPR starts. But we're called 30-ish minutes, 20 to 30-ish minutes into her CPR. So now we start to make arrangements for transport and get her to the operating room to get her cannulated. 120 minutes of CPR, right? All of those things that I just showed you, not very favorable, right? So, would anybody cannulate her? Okay, lots of people. Impella? No takers, right? Central ECMO? No real takers. Peripheral? Yeah. That's what we did. We cannulated her with peripheral ECMO. 56 hours later, Kylie was decannulated. This is a photo taken a couple of years ago when she came during Heart Pledge Day to, spend some time with us and share her story with audiences, right? Which is always the most powerful thing. And that's the danger of what I'm talking to you about, is without a lot of evidence, we have to come back to experience and stories and physiology, and as we build that evidence as a community. But I always like to think of what George Orwell said, break any of these rules, break that rule about that 100 minutes of CPR, rather than doing anything outright barbarous, which would have been to not try to rescue a 37-year-old woman, right? So to kind of put everything up, wrap everything up here, so the important things are to have a strategy. So the right device for the right patient at the right time. When you decide to rescue somebody, be cognizant of, do they need biventricular support? What is their oxygenation? Are they going to need lung support? Is it post-cardiotomy? Is it cardiogenic shock? Is it acute? Is it chronic? Is it ECPR? Where is your surgical expertise? Where is your ICU expertise? What is your center comfortable with? You can do a lot of things, but if nobody knows how to look after those patients, the outcomes are probably fairly predictable. Josta Pedersen at the clinic used to say, it's safer for me to perform an aortic root replacement than an isolated AVR, because that's what he did every day, 3 of them. And he wasn't kidding. He was a masterful surgeon and just a gentleman. But this is the point. Know your system, know your surgeons, what's going to work for you. I've already mentioned oxygenation before, but acute versus chronic LV failure might have different strategies for cannulating because it may have implications for potential for recovery. And are you going to escalate them into durable LVADs territory? We use the bridge-to-bridge strategy, and I showed you that photo of a bridge in Edmonton, you have to be flexible. You have to expect frequent mode conversions. You have to expect you're going to go for washouts. You have to be prepared mentally, and your teams have to be prepared morally, because moral injury can recur. You can imagine what the unit was like when we were talking about withdrawing on Marty after he's been in the ICU over 4 months and he's awake and talking to everybody, right? Trachs decannulated. But we did something nice for Marty, which he wanted. And it worked out to be an end-of-life care process that is something that we can all look at and say, yeah, we tried. So mechanical circulatory support is no longer just taking a frying pan and holding off the Grim Reaper, right? Like, it saves lives. The question is timing of introduction and case selection. And always, always, always know what your exit strategy is before you enter a vessel with the cannula. I was reminded how old I was last night when we were talking to the trainee, so I thought I'd throw this in. Is there anybody in this room who's heard this song from the 1980s? Fairgill Sharkey, A Good Heart These Days is Hard to Find. I'm not going to sing it for you. So please be gentle with this heart of mine. For those of you who are interested in the critical care of cardiovascular patients, we have the Canadian Cardiovascular Critical Care Society and former secretary sitting up here in the front row. It's a great venue for us to learn and share, and we welcome you to join. Look forward to the future. And let's go.
Thanks very much for that wonderful talk. We'll open up to questions. I'll just unmute the room. And questions in the room or online, I'll open the chat window as well. Any questions? Hey, right.
Gurmeet, great talk, thanks. You kind of alluded to this a little bit at the end, right? Challenges in these circumstances when you're contemplating these type of major escalations in therapy is the discussion. There's the person that's at not the head of the team, but oftentimes the first person involved who's already invested a fair amount of time and effort and emotional energy saving somebody, and then you have the other team members that are called in and come in late. With an outside lens, may put the brakes on what that first person that hoped would happen. Can you tell us sort of how you navigate that? You often are probably the one coming in, pumping the brakes and maybe saying, no, we should go ahead. And so that's an interesting process, and it sometimes generates some controversy. So comment about how you handle those sort of situations.
Is this easy question as a reward for something I did to you in the past? No, thank you, Greg, for your comments, and that's an insightful question, and I think I referred to that case specifically because not everybody survives, right? And it's a question of how you make those choices. So what we've done is certainly on the ECMO side, right? We established a culture early on of shared decision-making for the decisions to cannulate. And that became part of our culture, right? It occurred to me, I was, I would come in and do the cannulation and stuff like that. One time I got stuck in an elevator when somebody needed to be cannulated in the unit. I'm like, well, how's this gonna work? Another time I was actually on vacation and I got a call from one of the fellows from the General Systems ICU about cannulating somebody, right? So I said, well, you can't have one person who makes the decisions, right? And I think you referred to that, right? So from the inception, we had this shared decision-making model whereby we had a lot of respect that was brought in. During the pandemic, I tried on several cases to say, yeah, I don't think we should cannulate this person for VV ECMO or not. But the wisdom of the group is often wiser than the individual. And so you have to give due diligence to the opinions. Everybody has to feel heard. In the case of Marty, I'll tell you specifically that his congenital cardiologist, who had known him for over 20 years, really struggled with coming to terms with this end of life process. And so what we did, Greg, we had meetings as groups. We tried to be objective. If somebody raised something as a question or as a concern, we'd explore it to the end. Now, sometimes, somebody will raise something, and I'm sure you've been in this situation in the CICU, and you're just like, that's absolutely asinine. What a waste of time. But you know what? If somebody has raised that and we're going to respect our colleagues, then you pursue it with some interest. It doesn't have to be too vigorously, but to show that you've done due process. So I think being open and discussing things with your colleagues and just being transparent all along. I think that is how you evolve that culture. It's easier in some environments than others. It's easier with some cases than others. I don't think there's a universal recipe that works, but I think the principles of talking to your colleagues and always maintaining that openness to hear, I think that's probably a long way of saying sometimes it works and sometimes it's harder.
You guys have a formal QI process to look back?
Yeah, we're going to, post-pandemic, it sort of fell into quite a disarray, but we're sort of reassembling that and discuss those cases and use those as learning points and whatnot. I think it's important to remember, you alluded specifically to ECMO, most of those patients are going to die, the VA ECMOs. The vast majority of those patients are going to die. That's why we use that technology. That's why you don't put a $100,000, I guess it's 140 now. What is a heart rate cost? 120,000. Whatever, that's why you don't put that pump into that patient. So, but your system, it has to have the resiliency, not only with patient capacity, resource implications, but staff morale to also be able to do those things. So you do have to be thoughtful about how you deploy it. It's easy to get up here and beat your chest and say, look at what I do. It's a little bit more complex than that, isn't it? And quite nuanced when it comes to decision making. Jeff.
A couple questions. So first is, you talked about patient selection, and over the last 10 years, it seems that the AMI shock patient has had more evidence to suggest that ECMO may be a more challenging population for that. I was just wondering if your approach to the MI shock patient and what type of rescue modality has evolved over time. And then my second question is, when you're talking about physiology, do you ever use a balloon pump as the LV venting strategy? There's some case series that suggest that may be equivalent to an Impella in terms of a less costly and maybe less complicated way to prevent some of the complications of peripheral VA ECMO, and specifically the LV afterload and the coronary malperfusion.
Yeah, no, I do think, there's a place for Impellas. I mean, the Japanese registry data for many, many years has been pointed to as, look, the outcomes are superior for patients who had who had balloon pumps in situ. I think if you really need to unload a ventricle, a balloon pump doesn't really achieve that much, right? I didn't put the pressure volume loops in for the balloon pump, but they're not that impressive physiologically. It does help with coronary perfusion for sure, and some reduction in LV afterload.
Impressive sending blood backwards towards it.
And also the other thing that I think that the balloon actually does, it just sort of encourages the aortic valve to open. It encourages some opening more than anything else because of that drop in the afterload. But I think that this is going to come back to the first part of the question for the AMI population. I think it's actually LV unloading. So when we're in the operating room, right, what is the one thing we are terrified of? LV distension, right? We want that LV to be soft and empty. So that is the same principle. I don't understand why, you know, people will, there used to be a culture of people fighting back and saying, oh, that pulmonary edema doesn't look so bad on chest x-ray. Now we don't even bother. We're just like, we're gonna unload that ventricle from the get-go in the best way we think for that patient X. If you look at the ECMO cardiogenic shock, acute AMI shock, cardiogenic shock trials, there's no, you know, there's some standard venting criteria in ECLS shock, but that's not how I would have ever treated that patient. I would have vented all of them. Is that going to change something until we have a trial to say yes or no? I can't answer that with any degree of certitude. What I can tell you is if you believe that LV distension and all of its after effects are bad, then why wait for it to develop? It's sort of like if you intubate somebody and put them on mechanical ventilation and they start to develop some pulmonary edema, why would you wait for it to get worse before starting lung protective ventilation strategies? I think there's an online question.
Did someone have their hand up there online? If you could speak up.
Hey, Gurmeet, it's Kristen Lyons. I actually was I put my hand down because it was kind of asking what Jeff did in a way. And I did come into your talk a little bit late, so apologies. But then are you generally then putting the vents in these people? Is that the method that you're using the most? It wasn't, clear if I missed that from what I saw in the presentation.
Yeah, no. Okay, Kristen, great to hear your voice again. Sounds like you're doing well. So yeah, with that situation, so if we're putting somebody on central ECMO, the majority of the time, if we think that we're gonna have to progress to a durable VAD, like we're already thinking about that before we're cannulating somebody, we're sticking that 30-32 French into the apex. Some surgeons, if they think this is they just need a few days to kind of cool off, will probably just put an LA/cross the mitral valve into the LV vent through the right superior pulmonary vein. But we do try to decompress the left heart most all of the time. It's occasional cases where you do have surprisingly good LV ejection where we wouldn't vent centrally, and certainly peripherally same, right? Like there was a time where some of our peripheral ECMOs, we were putting apical vents through a left anterior mini thoracotomy. We haven't done that for a while yet, but because we're probably doing more central, but there's a lot of ways to do it. I mean, you talk to Roberto LaRusso and he does it all from the venous side through the PA, right? So I think the principle is the same.
Thanks, and go oil, right, Gurmeet?
Thank you. Paul.
Thanks, nice, Gurmeet, and nice to see you. You know, well, you know, as the person who's often pumping the brakes on the shock call, you know, to Greg's comments, you know, it's you know, these cases are challenging. You know, and I'll be honest with you, my heart often sinks when I get the call because they're always a desperate situation. And what's perhaps more frustrating is the information that comes across is quite incomplete. Mm-hmm. And whether that's simply because people haven't had a chance to invest, or it's just everything's been so chaotic, you know, in terms of you know, maybe some finer details of the case that are actually quite important. And you know, I think that's part of the nature of the business that we're in. We'll challenge you a bit on the ECPR piece. I mean, you know, I think it's great to bring stories here. You're in a room that's got a bunch of cardiac surgeons. Results matter. And you know, I think you know, when you look at these things from an economic standpoint, I mean, these evaluations become very difficult. But you know, to say that, you know, Impellas are worth $50,000, you know, putting someone on ECMO, you know, with very low chance of survival that might impact the cardiac surgical list the next day, that has impacts on people that might pass away. You know, there's a lot to this, right? And I think, you know, the resources that are consumed under those circumstances, I think, can't be underestimated. Maybe somewhat difficult to cost, and the you know, what's maybe more challenging to cost is the you know, the deferred care that often happens related to that. And I think, you know, the I respect that there's, some challenges, with the moral injury to your team related to your one long stay patient. But I think there's a lot of challenges with teams when you're doing desperate things in desperate circumstances and aren't having good results. I think it's, Dr. Maitland used to say you're only as good as your last case. But I think it's more complex than that and nuanced. Appreciate that, but I would challenge you a little bit on that piece because I haven't drank the Kool-Aid.
Well, Paul, first of all, thank you for making the effort to come. It's good to see you again. And I'm going to ask you a question that I was asked in my fellowship in Calgary, critical care. What is the only positive predictor 100% of the time of mortality in the ICU? It's not renal failure. It's not your LV function. It's a pessimistic intensivist, right? That's the question that you asked me, right? And so, yeah, I believe, but I'm also the guy who puts the brakes on. So we track our consults. So I presented you positive stories for a reason, to show that with good decision-making, you can have good outcomes. And I think I was fairly transparent about the fact that most of these people don't survive if it's acute cardiogenic shock, but a lot of them do with bridge to bridge, and they live good lives. So with respect to the data, we track all of our ECMO consults. We cannulate maybe a third of the consults we get. So to your point about we don't have the right information, it's incomplete data, we're not cannulating those patients. We get calls all the time. Yeah, we've been doing CPR for 45 minutes. Can't help you now. By the time we get the patient from your center to our center, and you've got all these other factors where no, we won't be able to help you. So we are fairly, I think, transparent about our limitations in being able to do all this. Perhaps I didn't communicate this effectively. I'm not a fan of using the Impella just to unload the LV. That's why we do that big thing. It's 60, 50 grand, whatever you want to call it. But there is a way to use the Impella as a bridge to a bridge system, right? In cardiogenic shock in the right patients. It's probably going to be very helpful in some post-cardiotomy shock patients. Close the chest, don't have to have an oxygenator in line, just unload the left ventricle, give them a few days. However, the point about cost is, I think you're even understating the cost, right? There's so much that goes into these to rescue one patient. You're absolutely right. And I would not hesitate to say that the value proposition isn't there for every patient. And that's why we do have to be selective. I would agree with that. I think that some of the things that I referred to about trying to rescue every patient, I mean, you just can't do that. We just can't do it. I would agree with that, yeah. Richard.
Just a follow-up on Greg's question, but more specific. So surgically, one of the things that we see happen from time to time is someone comes to the cath lab with an acute MI, they're sort of talking, nauseated, vomit, get intubated, arrest, and then Lucas is started, and while the cardiologists are fervently trying to open up the vessel, and then the shock team is activated, CPR has been. The patient is unidentified, so you don't know who they are, what their comorbidities are, etc. And then the shock team has to make a decision, not with 45 minutes to an hour, but sort of in 10 minutes. Of course, the interventional cardiologist wants to do everything to extricate the patient from that situation. So separate from post hoc QI reviews, are you aware of any studies, literature to help guide decision-making acutely in a very short timeline in that scenario? And if not, what strategies does your group use to bring things to closure in terms of making a rapid decision?
Yeah, no, good question. So in terms of the literature, I think Jeff, you referred to, right, some of these VA ECMO and acute MI shock trials, they've all been negative, right, to use VA ECMO for acute MI, right? The trials would tell you that there's no benefit. So, but it also comes back to the fact that those trials aren't that patient that you're necessarily referring to. And so that creates a degree of complexity that I struggle with every day, of course. in terms of trying to make the decision in a rapid way, we have, 3 people that are basically going to assemble in the cath lab immediately, which will be the surgeon, the CVICU, and the VAD team. And oftentimes the advanced heart failure cardiologist is the one who's made the call to activate the team. And it can be very rapid. The first things are, what are the exit strategies here for this patient going to be? Would this patient ever be a VAD or a transplant candidate? If not, then okay, what are what are we dealing with here physiologically? What, is there a point in trying to give them a short trial, like cannulate them and then try to fully revascularize them, whether it's in the cath lab or just take, sometimes we've actually decided just to take people to the OR and do, revascularize them fully and then bring them out on ECMO until their hibernating myocardium recovers or whatnot. So that the only answer to that is a consistent, I would say, across the spectrum of all these patients is assembling all those stakeholders, or at least having input from all those stakeholders right away. And I find that most of the time, consensus is achieved pretty rapidly. I don't know if your experience is different in your cath labs or.
Can be very rapid, but there are occasions where there's a difference of opinion. But I think of the last time this happened to me as a CVIC, Friday evening, 9 p.m. The others are at home, rushing in. Surgeon also not in the building. And then, but decisions have to be made. I think it's a vibrant area of qualitative research, rapid decision-making in shock teams under difficult, hyperdynamic circumstances. But my question would be, when there is disagreement, like, how do you resolve that if there's not consensus? There often is, but sometimes there's.
Well, listen, we don't have a formal, like a document that would help guide that, I guess, would be the honest answer. Sometimes we walk away with somebody saying, I still think this is a bad idea to do this. That's usually me. And it may or may not end up well, but at the end of the day, I think the consensus of the group, the majority, has to take precedence. And once you walk away from that conversation, the professional thing that we all have to put upon ourselves is to keep those conversations behind closed doors, because it doesn't help the patient, and it certainly won't help care for caregivers down the road if they feel that there wasn't concordance in decision making. So yeah, I agree with you. That would be a very interesting qualitative research study, but I don't have the answers.
Well, we're top of the hour, so we'll close out. Thank you very much. For the rest of your morning.